Navigating the Perplexing Waters of Andropause, Part 2. Dr. Robert Carlson. I previously talked about the different lab assessments that I would use for a hypogonadal man, including total testosterone, luteinizing hormone, sex hormone binding globulin, and I'd like to show you next how that really plays in to calculate a bioavailable testosterone. Also estradiol, because it's very, very critical. It's extremely important in controlling estrogen levels. Progesterone, because it does protect the prostate. It does reduce stress-induced abdominal fat. It does help you sleep better, and it does reduce coronary artery disease. Also helps men with CPAP masks sleep better at night, take deeper breaths. I always look at liver function tests and the prostate-specific antigen. This is a technique that I use for calculating the free and bioavailable testosterone. And this is the website here as shown. Now what it does is it tells you about the effects of sex hormone binding globulin. Again, when I look at the three components of testosterone as a number for the total testosterone, one component is the free and available. The second component is the part that's bound to a protein called albumin, and it's easily transferred, and it's really both those two together are bioavailable. The third one is the effects of something called sex hormone binding globulin. This globulin increases as we age, but what it does is it binds testosterone and never allows it to work again. I referred to it as the Hotel California of globulins, where you can check out but you can never leave. So high sex hormone binding globulins are actually related to increased prostate cancer, as is low testosterone levels. But the key here is if you have someone with a very high sex hormone binding globulin, as I'll show you this calculation, that they will actually bind up the testosterone, and even though you might have a normal level, will actually be too low if you're only using the normal, say, 200 milligrams per cc of the mixture of cypionate and an anthate. This is an example of a patient. His serum testosterone was 803. Interesting, his luteinizing hormone was 2.9. I like it really less than 1.5. So to me that makes it seem like the brain isn't that happy with this available testosterone level. The next thing we'll talk about later is progesterone. But I like progesterone levels certainly above 1.4, if not up to 2 or 3. And I use that to help men sleep, and also men with fibrotic prostate tissue or increased abdominal fat. But in this particular individual, you'll see his sex hormone binding globulin is 109.5. Now they say the range is 19.3 to 76. I like it below 25. And there have been studies that showed that men who have diabetes, it's preferable to have the sex hormone binding globulin below 15, because that allows more testosterone to be available and also will reduce these fasting sugar levels. So in this particular instance, the sex hormone binding globulin is very high. In fact, on this particular individual also, his estradiol is rather high. I like that 20 to 25, maybe 15 to 25, never over 30. And quite frankly, I see elevated estradiols all the time in men who are on testosterone therapy who are not on anastrozole as an estrogen blocker, and they'll walk in with estradiol levels of 150, 200, that of a 20-year-old girl. So, and it's also associated with increased swelling, increased bloating, also high blood pressure, increases heart attack rates as well. So in this particular calculator, you'll see I entered the albumin, and here, and the sex hormone binding globulin and the testosterone. And that's the program that it does. So here you'll see the bioavailable testosterone. Even though walking through the door you have a testosterone of 803 and everybody's high-fiving because it's so good, his actually bioavailable is only 170. I like that 400 to 600, and in some cases even higher. So you can see this is very important to know the sex hormone binding globulin, and that just the serum testosterone and not even the free testosterone is enough information. So this tells you the bioavailable. Now, the other thing I had commented earlier is the way to lower sex hormone binding globulin is to give testosterone. Testosterone is a negative feedback to the liver, reducing sex hormone binding globulin. Therefore, after sometimes 3 months of therapy, individuals will have 40, 50 points off their sex hormone binding globulin. That means they have more free and available testosterone if their levels were identical from when we started. These are the forms that I use and that often are provided for the men's urology and sexual health order forms. As you'll note, lower in the form there's testosterone, anastrozole, a combination of testosterone, enanthate, and cypionate. I'll talk about that. And then a trimix. On this particular one, there's so much more components that you can use, but these are just some of the basic ones that I use in men. And I'll comment on other ones that I use. The testosterone cream, they talk about 50, 100, 150. I start at 200 milligrams per cc in a cream and apply it daily. In some cases, men are at 1.5 cc's or 300 milligrams. The only thing you need to continue to remember is that there's a higher aromatase activity in the skin. So using a cream will create more estrogen levels. Of interest, there's also a higher alpha reductase. So men using creams often have a little better result with erectile dysfunction with higher production of DHT than the injectable. But I often use the testosterone cream in individuals who are extremely frightened of using the injections, and in those cases I try to move them even to pellets. Using between 7 to 9 of the 200 milligram pellets that are inserted in a little small incision in the buttock area. Anastrozole, there is a range between 0.5, 1, and 1.5. I use just 0.5. Men who have no elevation or no significant elevation of estrogen, I'll just do it once a week. Men who have a propensity for of having higher estrogen levels, specifically estradiol levels, I will give them twice a week, 3 times a week. And if they call me and say, hey, I'm really having night sweats, and I really feel bloated, I'll actually give them an anastrozole capsule once a day for 2 weeks straight, and then have them go back to their normal regimen of 1, 2, or 3 a week, usually 2 or 3 a week at that point in time. This is very well tolerated. It can be taken with or without food, at bedtime, in the morning. It doesn't make any difference. The anastrozole is very well tolerated, and it will control the estrogen levels, which again are related to higher heart disease, as I outlined previously in the other title of the other video, as well as reduced blood clots, reduced prostate size, reduced PSA, reduce prostate cancer, reduce erectile dysfunction, reduce man boobs, reduce belly fat, reduce night sweats. So it's pretty understandable that none of those things sound very good to any man, and anastrozole will control the estrogen. In women, estrogen is amazingly important, and that's where this estrogen paradox comes between men and women. The testosterone cypionate enanthate oil injection. Now the key to this, and I usually use a 200 milligram per cc, and you can actually do this injection once a week. If you want, you can actually try to break it up to half a cc and put it in a 25 gauge 1-inch needle and inject it into the tummy fat. You can also be injected with a 25 gauge into the buttock, into the thigh, so you don't necessarily have to use that 22 gauge, which can sometimes be a little frightening to individuals. The reason I like the testosterone cypionate, it peaks in about 36 hours, lasts about 7 to 10 days. Enanthate peaks in about 4, maybe 5 days, and is around for 2 weeks. So the key, though, to measuring testosterone levels is you need to have them draw the blood the day before the injection. Because if they do it within 36 hours, it's going to have very, very high levels and will appear abnormal. So The key is the best time to do it is when it's at its lowest, the nadir, which is, say, day 6 of a 7-day course. Also, I like a lot to use nandrolone. I use nandrolone and testosterone. I use a lot of nandrolone, especially in individuals who have shoulder injuries, rotator cuff injuries, surgeries on their back, surgeries on their arms, surgeries on their shoulders, surgeries on their hips and thighs. You know, it's just all these individuals will have tremendous amount of aching, and you can add 1 cc of the nandrolone decanate with the testosterone, and it has dramatic reduction in these aches and pains in these individuals. And you just need to use the dose initially for about maybe a month or 2, and then reduce it down by half. But I find the combination of testosterone and nandrolone are wonderful, and I use them in both men and women. In women, every other week or every 3 weeks, men every week. And then lastly, on this particular form is the Alpaf Trimix. Now, certainly a couple of the testosterone itself, both topically and injection, will increase DHT, which will dramatically improve erectile dysfunction. Viagra, obviously, and Cialis are good alternatives. I've actually been using a lot of Cialis, the 5 milligram for urinary obstructive symptoms, so like a BPH, and you can use that 5 milligram a day, and it's dramatic improvement, and you don't have to use things like Flomax that have some bad side effects. But these are individuals who have significant problems with erections. Trimix is actually a very small amount, 0.1 to 0.2 cc's, is injected right at the base of the penis, and it provides an erection that will last 4 or 5 hours regardless of an orgasm. And so men who cannot obtain or maintain an erection using Trimix can dramatically change their life and their love life. So what is appropriate for dosing and why? Compounded medications, I think, are really important because they give you and your patients options. And instead of one pill fits all and you have to satisfy the downsides, it gives you so many options. By the way, you know, the androgels that come in those little packets, they're about a quarter of what you would use in the 200 milligram. They're only like 50 milligrams per cc. And they're about $460 a month compared to the gel that's between about 60 to 80 per month, depending on the concentration you use. I like creams and gels, also application in men on the arms, on the legs. Also, I use a fair amount of men are getting excellent levels using the creams and gels on the scrotal area. And because of the format of the scrotum, the infolding of tissues, it provides a larger surface area, and it's absorbed very nicely. Injectables, again, 100 to 300 milligrams. I like the combination of the enanthate and the cypionate. It kind of draws that out, and then you don't have the up and downs that you might have. Another product that's been used is propionate, which is peaks in like 4 to 6 hours and is gone in a day. I think that's ridiculous. I don't think there's any benefit for propionate, and that's why I think that the best combination is this cypionate and enanthate. And it can be deep in the butt, the gluteal muscle, it can be in the thigh, also can be utilizing this small 25 gauge needle into the abdominal fat. As far as HCG, I like HCG from the standpoint of hypogonadism in younger men, or alternating between testosterone and a man who wants to get pregnant. Well, not the man, but he wants to assist in that activity. And what we would do is we usually range between 2,000, 2 to 3 times a week, sub-Q in the belly fat. And I also use Clomid, because Clomid is shown to increase sperm azospermia, as well as the activities and the motility of the sperm. So using Clomid 50 milligrams twice a week with HCG 2,000 3 times a week in individuals who have already been on testosterone therapy can often provide a nice alternative for individuals who are having to discuss and plan on having another child. Again, anastrozole 0.5 to 1 milligrams 2 times per week. By this, I use all kinds of combinations, 0.5 once a week, 3 times a week, every day for a certain period of time. And in some patients who are very sensitive, I actually give it to them every other day automatically. One other on this is progesterone. I like progesterone capsules. at bedtime. I use 100 milligrams in the men, and they sleep great. Like I said, it works great for CPAP masks. It also reduces visceral abdominal fat, the stress-induced abdominal fat. So use of progesterone is also another great alternative. And I check progesterone levels in all my men, and I administer them. I give them progesterone in probably 85% of the cases. So again, we talked about some of the options: creams or gels, injections, HCG. Now, one other thing is using HCG with testosterone. So if you're going to do that, you give a little bit of HCG, usually 1,000 twice a week, keeps the testicular size adequate, and that works out pretty nice. You can give the testosterone. You can actually give one of the HCGs inside the testosterone, or you can give the sub-Q HCG. I always tell men, you know, I mean, if they're really concerned about maybe testicular shrinkage, that this is a great way to increase the size, you know. But a lot of men don't care, you know. I mean, if their wife came to them and said, "Darling, I love you, but I'm leaving you because your testicles are too small," we let them know this is an option, so you don't have to get a divorce. But the key is HCG works great for increasing testicular size. Individuals who are trying to participate in the pregnancy, it works great for increasing the amount of sperm and sperm motility, and in conjunction with Clomid. And also HCG is fantastic in using for weight loss. Now I use, and I have written a book called the Siesta Beach HCG Diet, Siesta Beach HCG Diet, and it's on Amazon, and it's a Kindle form, and it's actually in Barnes & Noble as well, online. But basically what it talks about is using HCG as an injection between 200 to 300 units every day for 28 days, increasing from the 200 for the first 2 weeks to the 300 to the next 2 weeks, in conjunction with a low carb or less than 20 grams carbohydrate diet. And we've had some amazing benefits, and I think in working in conjunction with testosterone therapy, optimization of hormonal balance, it's a win-win. So what are the goals of therapy? You know, I tell people, if they come to me and say, look, I want to become a bodybuilder, I say, you got the wrong guy. I do not attest to that. I do not promote that. What I'd like to do is help them become healthy. I think that using testosterone therapy is a life-saving option. You know, I mean, I think low testosterone is very dangerous. And so raising testosterone levels to more healthier, younger levels is very safe and very beneficial. And one of the things people talk about is, you know, irritability. I don't see that. I see more men calmed and relaxed by it than irritable. Improves mentation. It improves all these cognitive skills, including motivation, and it just changes men's life around. It's actually very enjoyable for me as a clinician to take care of some of these men who come in with very low testosterone levels, and we just rebalance them, and in 3 to 6 months they are totally different people. It's amazing, and you have the power to do that as a clinician, and it's working in conjunction with a great compounding pharmacy like Hoy's, where you can reliably obtain blood levels that will achieve the goals of your therapy. So a couple complications of testosterone. Acne is one. I really don't see that too much. If it becomes an issue in men, sometimes you can use some Minocin, 100 milligrams for 5 days. Often just astringents and things like that. Increased red blood count does occur, but I actually don't think it's a bad thing, because what happens is when people are really sick, a lot of the patients I've taken care of, including the transplant patients and these individuals with, you know, extreme illnesses and in ICUs, they become anemic from chronic disease. They are so catabolic. They can't produce red blood cells, and they become anemic. What I tell my patients is, what we're doing is we're creating the absolute opposite end of that spectrum. You will now be anabolic. You are making red blood cells. you are making muscle, you are making tendons, you are improving your joint spaces. You're actually, some studies suggest even some stem cell processes that occur in the brain improving cognition. So again, I don't see a high red blood count as a problem. I've been told by patients who told them that a doctor wanted to stop their therapy because their blood count went up. My response is, why not go donate a unit of blood? And often I'll have my people do that three times a year. And you know, it's a very gracious thing. A lot of people need blood, and it's a very, very helpful. And sometimes you even get a coupon for a restaurant. Certainly, testosterone also will increase libido. In some relationships, that becomes a major entity where the man has absolutely no interest. And it could be related to some sexual dysfunction, some erectile dysfunction. But once you correct those things, correct the testosterone levels, the libido is dramatically improved. And these patients really do wonderfully. Fluid retention, I see that, as well as gynecomastia and night sweats in men who need better estrogen control. They have high estradiol, or in fact, you can look at total estrogens, and men eating lots of chicken and turkey or using a lot of Selsun Blue or some of these anti-dandruff things will have a lot of phthalates that can cause estrogen-like symptoms. So key is to maintain estradiol, keep it down around 15. Roid rage, I just think that's some Hollywood term. I do not see that as a real entity. I say, you know, in a nice kind of way, an asshole's an asshole if he's on testosterone or not. So it doesn't make any difference. But I think it's just a made-up term and doesn't really have any clinical relevance. As we talked about, reduced testicular size and reduced sperm count, certainly HCG and Clomid work are very, very good with that. One of the other thing is, and I see this sometimes in men, and now all of a sudden this premature ejaculation and erectile dysfunction turns into, he's a rock star. He can go for hours, and the wife is getting unhappy with that. So he's got extreme lasting power. And sometimes he gets concerned because he can't ejaculate. More often his partner feels like, well, there's just some lack of emotional tie, and that's not why he's able to ejaculate. And that's not the truth. It's truly physiologic. What I do is I continue the therapy, but I add Clomid. And Clomid at 50 milligrams twice a week for about a month, or sometimes even a month and a half, will actually increases the ejaculate volume and will allow a more easily obtained ejaculation. And this is, in some patients, they are staying on it once or twice a week for an extended period of time. It's harmless. It's very helpful for some of these men, and it's very effective as just an alternative. Again, you can get this Clomid as a compounded agent from Hoy's. I would not recommend going to get the pharmaceutical grade because it's so much more expensive. I want to comment on a couple other things about prostate cancer and testosterone therapy. There's a lot of horrible, horrible data out there that says, oh, testosterone causes prostate cancer. And a lot of the old urologists say, oh yes, testosterone causes prostate cancer. Well, by the way, they're the same ones who are giving testosterone shots to people once a month. Well, that's kind of ridiculous because it only lasts 7 days. And what do you do for the next 21 days? You feel crappy. So the answer is, there have not been any good studies that associate testosterone therapy with prostate cancer. There is no association with testosterone therapy and prostate cancer, and I want to show you that. In fact, there's a lot of studies now where men after prostate cancer surgeries, or even having the seeds placed, can actually go on testosterone therapy afterwards, because it actually helps mentation, maintains bone mass, reduces cardiac risks, and I'll go through a lot of that. This is kind of a summary about the effects of testosterone deficiency on cardiovascular disease as defined by the American Heart Association, recommending that men on androgen deprivation therapy, that's men who conceivably in the past with prostate cancer were told to never, ever, 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 never go near testosterone. It's bad for you. It'll make your prostate cancer activate. The answer is that's just not true. And these prostate cancer, they feel that individuals should receive testosterone, and that it will be very beneficial, and that they should just follow up monitoring blood pressure, lipid profile, and glucose levels in these men in androgen deprivation, because All of those things that I had talked about earlier, the side effects of low testosterone that are very, very dangerous, are just as dangerous in a man who has had prostate cancer and is now being deprived of androgen. So androgen deprivation therapy is associated with increased risk of cardiovascular events, including myocardial infarction, cardiovascular mortality, decreased lean body mass, increased insulin levels, decreased insulin sensitivity, higher serum cholesterol and triglycerides. So the bottom line is it's not safe. And these men, even though they've had prostate cancer, should receive testosterone therapy. Now that's something you need to talk over with your patients, and you need to also express to them there is a lot of data out there, and I'll give you the name of a book by Dr. Morgenthaler called Testosterone for Life that outlines it very nicely, and you can always refer patients to look at that on Amazon. So here's a study out of the Journal of Urology. Okay, this was done in 2013. So you have a urologist who's saying, no, never, ever, ever, never use testosterone with prostate. Here, in this case, they have 103 men who received testosterone therapy after prostatectomy, and actually there were 4 recurrences in the group on therapy. In the group that did not have any therapy, there were 8 recurrences. So increase 100% from 4 to 8 in the individuals who did not receive testosterone. So, and the PSA may rise with some of these people, but you just need to watch it and be careful. There's really a shift in the paradigm. This is another one from the British Urologic study. Low testosterone levels are related to poor prognosis in men with prostate cancer prior to treatment. So the key here is low testosterone is actually, as I talked about with heart disease, it also increases the aggressiveness of prostate cancer. So there's a shift in this paradigm considering testosterone, low testosterone, as a risk factor for prostate cancer. And it's lower, not higher testosterone levels that are related to a higher prevalence of prostate cancer, and also a poorer prostate cancer prognosis with more aggressive prostate cancer identified on initial surgery. Another study, this is Dr. Abraham Morgenthaler out of Harvard, a Harvard urologist for 25 years. He talks about testosterone therapy in men with prostate cancer, and overall he states the evidence fails to support the long-standing assumption that high testosterone levels lead to greater growth of prostate cancer. So at some point in time, the urologists are going to have to figure this out. And if you're talking to a urologist that's been practicing for 20 or 30 years, he may not know this data. You may need to provide him with this data. And because, quite frankly, the individual that's being hurt the most in this is the man who's already had prostate cancer, and now you're depriving him of androgens, and it's unnecessary. This was another study by Dr. Roden and also Morgenthaler out of Harvard in New England Journal of Medicine, 2004. 2004. Now, so why are the urologists today still telling you to stay away from it? Despite decades of research, there is no compelling evidence that exogenous testosterone has any causative role in prostate cancer. Another one, data from all published prospective studies. This is Dr. Renaud in Biochemical Molecular Biology, that all published prospective studies does not support that higher levels of circulating androgens are associated with an increased risk of prostate cancer. And in fact, patients cured of prostate cancer can be treated safely with testosterone with significant beneficial effects and beneficial results. Again, this is a 2009 article. This is Dr. Morgenthaler's book called Testosterone for Life. It really had some great insights. And, you know, it may not be a bad idea to send to your local urologist who's giving you a hard time that may say, you know, look, none of these guys should ever be on testosterone. Well, here you got a guy who's a urologist out of Harvard, been practicing urology for 25 years, says, wait a second, we've been doing this wrong for a long time. And in fact, the data that individuals are deprived of testosterone isn't really data. It's like a myth. You know, and it's hard to disprove a myth. It's easier to disprove a study, but this is a myth. It's like lore. It's like, is there really the Easter Bunny? It's hard to prove not. But anyways, the bottom line is Testosterone for Life is a great book. You should purchase that. Get that through Amazon, and it provides some lot of information, and so you can confront the individuals who've already had prostate cancer and are really struggling. One other thing I want to talk about is lipoprotein lipase. And I always say it's really a troublemaker. Now here's why. Think about this. Lipoprotein lipase is an enzyme that sits in your belly fat. And this is specifically makes visceral fat, that dangerous increased cardiovascular disease fat. Lipoprotein lipase is an enzyme that takes the sugar from your bloodstream and stuffs it into your belly as belly fat. When you have very low testosterone levels, this enzyme is now working 2, 3, maybe 4 times more fast. It's vigorous. It's taking everything and stuffing it into your belly fat. When you restore testosterone levels, it's shown that this lipoprotein lipase drops to almost nothing. So now the key is not only are you not forming abdominal fat, which in using testosterone, but you're now building muscle, which will help you burn more calories and burn more of that fat. I just find that visceral fat is the slowest to come around, but in the end, you keep plugging away at it, it will be reduced, and it will substantially reduce risks of all these metabolic syndrome type processes, including diabetes and dyslipidemias and this visceral fat and blood pressure issues. One last thing, just a comment on HCG therapy. I am a very big fan of HCG therapy, not only for men with hypogonadism, but also for individuals trying to lose weight. So let me just do this real quick. I want to comment on HCG because a lot of times there's a lot of crappy literature that's out there that says, no, it doesn't work, it doesn't work. I want you, if you get a moment, purchase my book on Amazon, and it will go through and it'll read every one of those studies, and they're just horrible studies. And I'll tear them apart, and I'll show you that, in fact, other studies have been very, very beneficial. So let me explain real quickly how HCG works. First of all, the key for HCG is people will go, well, wait a second. Women are pregnant, have high HCGs, and most women I've seen that are pregnant really are not skinny. They're not losing weight. They're gaining fat around their tummy, etc. And that's true. But the thing is that when a woman is 30 weeks along, her HCG levels are 70,000. We're using 200 to 300 units. When a woman is 5 weeks pregnant, i.e. the first time she checks the urine pregnancy test and it's positive, she has to be 17,000 units of HCG to be positive. We're only using 200 or 300. So what's the difference? Obviously there's a big difference, and what you do is you calculate the 5 weeks where it's 17,000, and you go back to day 1 of creation. And what you find out is that about day 3, 4, or 5 after creation, the HCG levels are around 200 to 300. So what does that mean? Interestingly, it's a very, very difficult time because right now the brain is being developed those first 3 to 10 days. The brain is being developed. The heart is being developed. By 19 days, the heart actually has a heartbeat. The skin, all the vital organs are being developed. So what's going on? This is big time. So how does your body get the needed nourishment that it requires to do all these tremendous metabolic processes? And the answer is, mom has no idea she's pregnant. How many women at 3 days after conception know they're pregnant? Very, very few. And so how can they eat better? They're still drinking alcohol or smoking or whatever. They don't know it for 5 weeks. But the body knows. Her body is creating this HCG that's traveling to her fat cells. And there are HCG receptors on fat cells in both men and women, by the way. And it's taking the fat out of those fat cells, delivering it to this growing embryo, nurturing it with the energy that it needs. Interesting, it also, by releasing this from the fat cells, produces other components like leptins that go back to your brain and tell you to stop eating. So the combination of everything is basically telling this mother who's eating wrong, eating badly, to either not be hungry, number one, because her body's taken over all the supporting of this embryo via the fat stores. And it's not until about 5 weeks that mom knows she's pregnant that all of a sudden she says, geez, maybe I better be eating better. Maybe I should stop smoking. Maybe I should stop drinking or whatever. But during that time, those first 3 to 10 days, the HCG supports this growing embryo. That's also how it works in you and I. What it does is it tells your body to use your belly fat as the primary source of energy. And that's burning the belly fat is the key to HCG. Now, I like a low-carb diet. So utilizing a low-carb diet, you have very low insulin levels. Low insulin levels are great because spiking insulin levels, like if you eat some carbohydrate or something, spiking insulin levels will tell your body to store more fat and block you from releasing any of the fat. Because quite frankly, insulin is a fat storage hormone. Repeat after me, insulin is a fat storage hormone. Check your physiology book. That's what it does. It stores more fat. We don't want high spiking insulin. And when you're eating sugars or this, quote, low-fat diet, which is just another goofy name for a lot of sugar diet, you need to be eating a low-carb diet. You need to avoid a lot of the carbs. The grains, specifically, there's a lot of studies out now and a great book called Grain Brain by Dr. Perlmutter Naples, and also a great book called Wheat Belly that talks about all the problems with these wheats making us fat and how they're so dangerous. So I like HCG used with about 20 grams of carbohydrates a day and no caloric limitation though. And I have so many patients now that are just unbelievably happy, and it's pretty easy. You can go on and off of it. You do it for 28 days, go off for a week or so, come back onto it until you achieve your desired weight. This is what the book is. It's called The Siesta Beach HCG Lifestyle. You can get it on Amazon. But it's a combination of navigating and optimizing success with testosterone therapy and other therapies. So it's a combination of things, not just hormone balance, but hormone balance will allow this process of improving body composition, not always reducing weight because it's increasing muscle mass and reducing belly fat and fat, but fat weighs 1/5 of what muscle. So weight loss isn't the key here. The key is changing body composition. Your pants falling off, you're tightening your belt because your pants will fall. That's the key. That's the success. So I'd like to thank you for listening to this talk about andropause and how to manage individuals with low testosterone levels, and that it is very critical. Low testosterone is a life-threatening disorder. It should be managed aggressively, and it should be managed wisely, maintaining low estrogen levels and optimizing the other hormones. Thank you very much. And I'd like to thank Hoy's Pharmacy for allowing me to do this talk.